Good afternoon. I'm Dr. Bill Wyatt again, and I'm with the American Orthodontic Society. I'm board certified in that organization, and it is an excellent organization if you're a general practitioner or a pediatric dentist and are doing orthodontics and want to learn it really good, then you can join the American Orthodontic Society. It's a wonderful organization. I myself am a general practitioner, but I've been doing nothing but orthodontics and a good bit of temporomandibular joint work too is mixed in with orthodontics. It's hard to, you can't separate that from orthodontics, so you need to do both of them. If you're doing orthodontics, you need to be doing some temporomandibular joint work also. Okay, I'm going to talk to you about one of our assistants. This lady was an assistant for a good many years there at the office and very good, and she had a TMJ problem. Her jaw joints were bothering her, and she had an orthodontic problem also. So we're going to go through several of these patients that had temporomandibular joint problems and had orthodontic problems. Seemed like at least half of the ladies that worked in our office had TMJ problems, and they also had orthodontic problems. But anyway, let's get into that deal, and I'll show you a real nice looking lady and good looking face. In other words, the facial division was good, and the no extra protrusiveness or lower vertical excess at all in there. And so looking at it from the front, it's a good facial structure too. But when we got to examining her, her upper jaw needed to be out further. Her upper teeth did anyway. When we got her relaxed and everything, her lower jaw came forward where it was kind of edge to edge. So, and that's where it wanted to be. And when she went back to where she normally chewed, it gave her trouble. So we had to try to advance the maxillary complex of teeth. We used a headgear that put force on the cheekbones up here, had a strap around the head, and had some bars coming across here, down like this, and then we pull the teeth toward that. But the pressure on the cheekbones was quite a bit, and we tried this on two of our assistants, and both of them need their maxillary teeth brought forward, but it gave them a lot of difficulty, and this area of the face would hurt. So this is the only headgear you could use without pushing back on the mandible. See, the Hickam chin cup had these fingers off of here, and you pulled up to that, and it had a bar that went back and a strap went over the head like that, and it's one of the best ones that we come up with, but it put pressure on the chin and would break out the tissue on the chin, plus it put a lot of force on the condyles and the fossa. And if you had condyles that were going back too far and the retrodiscal tissue was being crowded and giving you trouble, then you couldn't very well use a Hickam chin cup like that, or unless you used it in the daytime. Sometimes you could get away with the daytime when the muscles would hold the jaw forward, but at night when you relaxed, there was no way to wear that. So we have a problem of advancing the maxillary part of the face. It's when you need to advance the maxilla, the best thing I've come up with lately now is putting tads in the roof of the mouth and fixing some type of spring structure that'll move the dental structure forward, but not the palatal roof up there. We've already shown some of that in videos, and so that's probably the way you're going to end up bringing the maxilla forward in there. Alright, let's look at her facial structure. When we started, these teeth are kind of caved in a little bit over here. Now, what I was talking about a while ago, if they put a couple of tads or screws into the palate and run some type of a spring through here, where the spring actually, it would end up like here, and you'd have to push it back. In other words, if you had a deal like such, you came off and wound it around and it came out like this, then you push this back and attached it to the teeth back here. If something was attached to the teeth, and the spring would be pulled back to here, and it would be trying to go this way, have it tied to these teeth, and the teeth are united here, you could drag something forward like that. So in something, you'd have a couple of tads. Let me just kind of erase that and get a little white deal up here, like if the palate is up here and you had two screws or tads, whatever you want to call them, and you came across with something, a spring that wrapped around like this and came up this way. Now you could put two circles if you wanted to, and then you pull this back and hook it to something. It doesn't matter, some kind of elastic or even dental floss. I mean, you pull this back in here and hook it to something and have it pull the teeth forward. In other words, and your spring would be coming out like this. And if you made another swing, and now you activate it, you tighten this spring up, that would be a good way to put pressure on the maxillary teeth and shove back on the bone structure in this part of the mouth, which this is not supposed to move at all, but the teeth, you could get them to move a few millimeters on the dental arch themselves, and that would be one method of bringing this. That just have a spring that was kind of like that, and then you pull that back and hook it to these teeth back here. Now, several people have come up with some devices like that are advancing the maxillary structure, but we were trying to do it with a headgear, and I'll show you that. Now, we had some other problems here. We need to expand this laterally also, and we needed to expand the lower arch too. Let's get over here and look at it. Now, we've got some crowded centrals or laterals over here, crowded here, and we're going to have to expand the cuspids, and we've gone over that over and over again. You can expand the cuspid teeth, but you don't lean them out this way and let the roots stay there. You have to take the roots with the crown, bring it back over here, and there's nothing sacred in there. It's telling that cuspid it's going to have to move back over here, and I'm sorry that they put that word out for several years. People were extracting teeth down here when they really didn't need to. But if you take the cuspid roots and put them distal to the crowns, the crown is not going to come over this way. I'm sure that this research was done with students doing the work, and they had a short period of time to expand the cuspids and do all this. They probably just leaned them out. I don't know. I knew the guy that did it. He was a real gentleman. I mean, a real nice guy, and sorry to have to buck him in what he was saying was the way it went. Now we'll get a good look at these arches here, and we'll show them to you when we finish this case up. And we've got some 10 years out. We finished about 94, and then we'll show it to you in 04, 10 years later. So anyway, we'll go from this point that we needed the maxilla brought forward. We did it some with some, I'm sure we wore some class 3 elastics and brought this out to some extent, and did a little bit with that headgear. I didn't know enough about TADs at the time to put them in, but here's the mouth before we started on it. She was having TMJ problem, little, not too deep a bite. Everything was working real good. They're not real good class 1 on either side. The midline's a little off, and we got a good bit of crowding in these lower anterior teeth. And so I'm going to run on through here. And the upper, again, the expand it too. We'll expand, and we expand so many people's arches and have very, very little problem with it staying out there. We wear retainers, but they never run anything over the occlusal surface. Now you watch this expand too here. Now here is this reverse headgear that doesn't put any force on the chin, but it puts a lot of force up here on these cheekbones, and they get sore. And this goes around the head here, and you've got some legs that come down with the come through this little pad, and this pad you regulate it and press against these cheekbones, but they get sore. And then you've got these arms that come down, and we attach the upper arch to these arms and pull back on that. I've got some pictures here that might show that, and I've tried that on 2 of our assistants, and neither one of them could take it very long. It was too painful for them. So I've kid with the people in when I lecture a lot of times. They just have somebody lay down, you know, and put a pulley up above and something like that coming down, and hook this to your upper teeth and put some rocks or something in a bucket here on this pulley and have it pick your head up during the night, and that might bring the maxilla forward. I was just joking with them, but somebody may do it. Orthopedic people do that and put a deal around your head and pick your head up and give you relief on the neck. You know, orthopedic people have been doing that for years. I have a close friend who's an orthopedic surgeon, and he had me fix one of those things for myself. I had some little spikes in my neck, and it sure helped. So you might do that for yourself. Anyway, here's this reverse headgear that puts no pressure on the mandible. It's just pulling the maxillary teeth forward. There's another view of it, and it's got a bar across here, and you hook these maxillary teeth to that bar and pulls back on that. It's a neat deal, but you put pressure on these cheekbones, and any pressure to mount anything, and this strap goes around, so you pulls this up against your head, and it pivots off of the cheekbones, and you put pressure here, and it'll balance out, so it doesn't press much up here. It presses more right in this area, and that's where it gives trouble. So the guy that came up with that was real good, but it gives a lot of trouble. You put pressure on the cheekbones. It could be, you know, like the people that break their necks or something, and they put screws in the head up here. If you put a screw as big in that bone and maybe attached it to that screw, you might could do that, but nobody's going to run around with these screws sticking out in their cheeks up there. There's a lot of ways to do it, but I can show you some other ways to strip the teeth, and you got some stripping between the teeth, and then you close the space on the bottom arch from the front to the back, and you place on the upper arch from the back to the front, and that you'll get a 1.5 millimeters or 2 change in it, where you can change the contact of the teeth like that by doing that stripping and tipping. And you can just tip the teeth out and they will come this way, and tip these in a little bit, and you can accomplish it that way. So there's a lot of ways to skin a cat here, but this one we just didn't work very good. So anyway, here's her teeth. We put brackets and everything. We used little tiny brackets on her, and this was I think this was in 93. We were leveling the arch out and expanding it and doing all that good stuff, and just regular orthodontics, and trying to advance the maxilla to some extent. I don't remember whether we used a little of that stripping and tipping of the teeth, but we got them forward enough to where her jaws were comfortable in that position, and she got excellent class 1 relation too with it. We pulled that molar out of the kind of crossbite, and this is 93. This is where we hooked elastic, you see, to these teeth, going back here out to that headgear and pulling these teeth to the front, you see. We got some good out of it, but it was you just can't use something that gets people sore and bothers them. They just it's hard to get them to do it at all. Okay, here we're working on a molar, kind of a crossbite area back there, and we go through it just routine orthodontics now. And let's go through. This is 1993 and 4 of 93, and you can see the arch shape and everything's changing. And we'll get through and we'll come up to 94 now, and we finished the case in 94, and here we've got the deal off, and her teeth look really quite good. I mean, these are good patients, and they do wear this stuff, you know, except they couldn't wear these reverse headgears like that. Excuse me. But they are excellent patients. They are working on people and wearing this stuff too. So that's the way her teeth looked, and they look good in 94. And she doesn't have any TMJ problem either. Now we've got the 6 keys occlusion back here. If you're fanatic on that, these things are lined up good, and they stayed that way. Now this is 94. I'm going to go through several pictures back in. Now there's the. That's about as good a class 1 as you're going to ever get, I tell you. And that's 94. And I'm going to show you 04 here in a minute. This is 94 also. 94. And this is 94. And we've expanded both arches, built this out. We expanded this. We expanded the cuspids. And you'll see the cuspids roots are behind the crowns. And that lady's teeth are still there today. And it's 2018. I know her well, and if they weren't there, I'd hear from her, I tell you. And she knew how to take care of them too. Now, here, this is, I think this is getting to be 04. We didn't put the deal down, but it'll show you. Okay, here it is. These pictures were taken in 9 of 04, and that tooth cocked back in that area, and it looks exactly, I can't already tell the difference in them, 04 and 94. That's 10 years later. Here it is. Now if we went to 2018, I would almost bet you anything that they'll still be like that. They'll stay that. And these cuspids, you see them kind of angled this way? They're still there. Now we put a 3 to 3 retainer on there, but they said that didn't matter. You know, we're holding them out. From the other side, you see this 923 of 04 looks darn good. And I know this lady, if her teeth were to, she is really proud of them, and if they were to change any markable any way much, she would get a hold of me. She doesn't live too far from where I live here now. And you look at the upper arch, it's expanded too, and the lower arch is expanded, and we expanded the lower anterior and the lower, all around. We have expanded so many people's arches and have very little, if any, trouble with it. We wear retainers now. We don't run around, but this is 04. I notice some of the bonding is off of these teeth, but they're staying, looks like they're pretty good. There's no problem with them right now. It looks doggone good. And here's her smile, and this is 04. You'll notice she's gotten a little bit grayish, or there's some tint there in the hair and stuff, but you can see a little change, but she's held up good over these 10 years. And this is the end of this video. So it's got a little midline off. That's no problem as long as these teeth are interdigitated good in here. We don't mind. It'll be a little two-side discrepancy. Call that's a darn good looking set of teeth, and they've held up for 10 years. And if I could get some pictures of her here from 04 to 014 would be another 10, and 8 would be another. So this works, you see, and the retention is good, and it stays with them, and I hope you pick that up. So let me go back, and this is the end of that. I hope you gained something from these videos that we're trying to put on. I wanted to go through several in the ladies that have TMJ problem, so you can see what happens. About 80% of our TMJ cases were ladies, and about 20% men. And they make a pattern now. You get a comfortable jaw position. In other words, the fossa is something like this, and that condyle ought to be something that where you've got a space in there where your disc fits in between here. But back in this area is where the retrodiscal tissue is, and that's where the synovial fluid is made, the blood vessels and nerves and everything. It's really filled with that stuff. And it can't take a lot of pressure. If you put a lot of pressure on some people, it'll give them a fit. Now, some people seem to be able to take anything in there, but we get that comfortable, and you get the teeth meeting where they don't want to slide back and forth when you close, and you've got a winning situation, but you still have stress. And people can have so much stress, it doesn't make a darn what you do to this. They're going to have problems with the stress, see? And you can't fix this good enough to overcome a real stressful situation. Now then you can have traumatic situations where somebody gets hit in the jaw and it mashes the retrodiscal tissue, or you can have arthritic conditions too. But the main thing is to get the jaw positioned right, comfortable, and have the teeth fit where they don't slide back further. Now people who slide forward when they close just don't have very much problems with that. Okay, I'm going to hush and we'll close out on this. Thank you for watching, and I hope you get something out of this. We'll holler at you later. All right, let's get this thing stopped.